Hello, my name is Nada. I'm here to present you patient case of Lana Mims. She is 62-year-old African American female who was seen today in the internal medicine clinic for follow-up appointment for blood pressure evaluation and overall medication management. Lana was seen in the clinic 2 months ago and was started on atorvastatin at that time. Her previous blood pressure measurement were 161 over 87 and 164 over 83 when repeated. She reported similar measurements utilizing a pharmacy blood pressure measurement machine. She was referred to the pharmacy clinic for management of her blood pressure and to evaluate for overall preventative medication management. She is willing to pursue drug therapy for any and all of her conditions. However, she is not interested in quitting smoking at this time. Patient past medical history. She has hypertension, dyslipidemia, and osteoarthritis. The family history of this patient: her mother deceased from dementia, her father is alive and has heart failure and hypertension. Her social history: she is a current smoker, smokes 1 bag per day and walks 15 minutes per day. She is married for 35 years now. She has allergy to penicillin with hives. The medication she is taking is atorvastatin 80 mg once daily, multivitamin 1 tablet once daily, and Advil 200 mg 4 times a day as needed for arthritis pain. The high priority problem is hypertension and CV medication management, and the low priority is dyslipidemia and arthritis. For the assessment of hypertension, the patient is experiencing uncontrolled stage 2 hypertension as evidenced by her current blood pressure, which is 162 over 85 mmHg. She was seen 2 months ago and her blood pressure was 161 over 87 and 164 over 83 when repeated, while she had similar reading in the pharmacy blood pressure measuring machine, and this rules out what is called white coat hypertension and confirms the diagnosis of hypertension. She has hypertension but without compelling indications such as chronic kidney disease, diabetes mellitus, heart failure, myocardial infarction, bad angina, or coronary artery disease. The lab test came with negative micro or macro albuminuria. Contributing factors for this patient to have hypertension are age, race, ethnicity, gender, and females after 5th decade are more likely to develop high blood pressure than male. Cigarette smoking, family history since her dad has hypertension, and the OTC medication that she's taken, the Advil. The patient is not taking any medication for hypertension, but she has been trying to cut salt out of her diet and walking more. The goal of therapy is to reduce associated morbidity and mortality from cardiovascular events. For the assessment of hypercholesterolemia, it seems it's controlled according to her recent lipid panel, since show that total cholesterol is 162, HDL 50, LDL 78, and those are within normal limits. However, the triglycerides are still above the level and shows 168, but comparing to the previous reading, the patient is responding greatly since the reduction in triglycerides is almost 38%. The patient has a 10-year ASCVD risk factor of 18.4, which is considered high. For the assessment of arthritis, it seems controlled since the patient has no concerns about it, and the Advil that she's taking seems to control her arthritis pain well. Her vitamin D225 is in normal level, and the patient's lab test show normal blood glucose, normal TSH, and normal renal and liver functions. She has low serum creatinine, which may be due to low protein intake because the patient doesn't have severe liver disease or muscle dystrophy. For the plan, I recommend for this patient both the pharmacological and non-pharmacological therapies. For non-pharmacological therapies, we need this patient to consume DASH diet and to do physical activity for at least 30 minutes for 5 days at least per week. Smoke cessation, maintain normal body weight, and keep her body mass index within the normal range, and we need her to reduce salt intake. We need to maintain her blood pressure within the guideline limit, which is to be 130/80 or less. So for the pharmacological therapy, I recommend initiate lisinopril 10 mg once daily and hydrochlorothiazide 12.5 once daily. Then this dose could be titrated up to 25 mg once daily within 2 to 3 weeks if the patient tolerates the initial dose. I need this patient also to continue atorvastatin for 80 mg once daily, and follow up within 4 weeks to reassess medication efficacy and non-pharmacological patient response. The rationale behind this, according to guideline, is stage 2 hypertension should be treated with 2 or more antihypertensive agents with different classes of or mechanism of action. Section 10.1.1 in the ACC/AHA guideline 2017 shows that Black patients and other patients age 60 or more tend to have greater antihypertension effects with calcium channel blockers and thiazide, and thus make them ideal first-line monotherapy or as initial agent in multiple drug therapy. Recommendation number 58 in dyslipidemia guideline 2017 presents that further reduction in the cholesterol, specifically LDL, for high-risk patients beyond established target using statins leads to more reduction in ASCVD. This with grade 1 level of evidence A. Atorvastatin 80 mg is considered high intensity statin and is suitable for this patient since the patient has 10-year ASCVD risk of 18.4 and is considered high. The non-pharmacological therapy are recommended by the ACC/AHA guidelines for controlling both hypertension and dyslipidemia, and so this will reduce the cardiovascular event. For the monitoring, we need to monitor patient blood pressure, serum creatinine, BUN, and potassium, and we need to consider checking baseline liver function tests and monitor for jaundice as a sign of liver function, or sign of liver failure. Hydrochlorothiazide, we need to monitor also the blood pressure, serum and urine electrolytes, uric acid, blood glucose, renal and liver functions. For the patient education, encourage this patient for smoking cessation, and the patient should be aware of side effects of antihypertensive agents. For example, the lisinopril causes hypotension, dizziness, high serum creatinine, syncope, headache, and cough. Hydrochlorothiazide may cause hyperglycemia, hypotension, dizziness, headache, and electrolyte disturbance. This patient is encouraged to avoid systemic non-steroidal anti-inflammatory when possible, and consider alternative analgesics such as acetaminophen or topical non-steroidal anti-inflammatory. Adherence to medication is crucial and plays a major role in controlling disease. Also, flu vaccine is recommended for this patient. There is some points I want to discuss regarding the United States Prevention Service Task Force guideline. It addresses the decision to initiate low dose of aspirin for patients 60 to 69-year-old who have a 10% or greater 10-year CVD risk should be an individual decision, and this came with grade C level of evidence. So because the patient is asking for management of her blood pressure beside the prevention medication management, I found that a controlled randomized trial of low-dose aspirin in primary prevention of CVD in women, it displays that prophylactic dose of aspirin 100 mg does not show any benefit in reducing the risk of major cardiovascular events, risk of total stroke, ischemic stroke, hemorrhage stroke, and no significant effect on the risk of myocardial infarction or death from the cardiovascular causes. So I don't recommend this patient to take aspirin for prophylaxis. For the COMPASS trial, the patient does not fit the inclusion criteria for that trial since the participant on that trial had at least one cardiovascular event, and they are seeking secondary prevention using rivaroxaban alone or in combination with aspirin. Thank you.